Hello and welcome to Luncheon Law. I'm Jeremy Hodder, Supervisor of Risk Management Services here at MICA. Thanks very much for joining us today. Today's presentation will begin promptly at 12:15 and end at 12:45. We may go over time to answer questions, but if you must leave us at any point during the presentation, the full webinar, along with questions, the PowerPoint, and any additional material will be uploaded to the MICA website within 24 to 48 hours of the webinar's conclusion. As we have several officers and practices attending today, you will be placed on mute throughout the presentation to eliminate any background noise. You can ask questions, and we certainly encourage you to do so throughout the presentation by using the Q&A button on the toolbar at the bottom of your screen. Questions will only be seen by the presenters. We want you to give us feedback, and we're always grateful for your thoughts and suggestions. There are two options. Firstly, following the conclusion of the webinar, a survey page will open in your browser. If you do not wish to complete this, a survey will also be sent later today to the email address that you registered with. I'd like to give a warm welcome to our speaker today, Christy Chait, who's a partner with Jones, Skelton and Hokuli plc. Christy focuses her practice exclusively in the area of medical liability and healthcare and serves as the firm's medical liability and healthcare trial group leader. She's dedicated to defending all types of medical service providers, nursing homes and hospitals, and counsels clients in various healthcare administrative issues. An avid supporter of women in the law, Christy is an active member of the Arizona Women Lawyers Association and leads the firm's Women Lawyers Affinity Group. Over to you, Christy.
Thank you for that introduction, and this is a discussion for healthcare providers and healthcare offices, including staff, for guidance on compliance with the Americans with Disabilities Act and the companion law of the Arizona with Disabilities Act. Briefly, as was mentioned, I represent physicians and healthcare providers now for over 27 years, and my background is in malpractice cases. But about 20 years ago, I represented a physician in a medical office in a lawsuit involving a deaf patient. Not only was the issue about the management of the patient's fracture to her dominant hand an issue, but the communication with the office and the physician about that treatment was a significant issue in the case as well. The patient had not had informed consent through an interpreter through any of the visits or procedures, and therefore did not have what was termed as effective communication. So that brought me into the area of understanding the interplay of the Americans with Disabilities Act and the potential for healthcare providers to have some liability in that area. I have represented a number of physicians and offices in alleged discrimination matters involving HIV, failure to provide interpreters, service animals, mostly in the setting of civil rights complaints and investigations, but also some actual lawsuits. Briefly, the Americans with Disabilities Act was signed into law in 1990. It was intended to require access for employees through their employment, and also to impose accessibility requirements on public accommodations. We will focus mostly on the public accommodations issue and as that relates to healthcare provider and healthcare provider offices. The Americans with Disabilities Act is very clear that categories of protection from discrimination under the ADA include race, color, national origin, sex, religion, and physical and mental disability. The focus of my discussion will be mostly in the area of physical or mental disability. Places of public accommodation covered by the law do include specifically medical and dental offices and healthcare facilities. Typically, when there are allegations against healthcare providers, it is either for failing to allow entrance into a facility or office, or being treated differently than a disabled person as it relates to services or medical care provided. This discussion will focus mostly on that last part about treating patients differently. Usually physical barriers in facilities typically deal with landlord issues, and they're not routinely issues for the medical office. Requirements for physicians under the ADA are that patients have effective communication irrespective of hearing, vision, or speech disabilities. Ensuring effective communication is something that there's typically a lot of questions on and never really just one definition. But effective communication should be established by considering the nature and complexity of the communication with patients. Typically, it is understood, for example, that when taking a patient history or discussing a serious diagnosis and treatment options, there should be some aid to disabled patients so that there can be effective communication. Requirements for physicians as it relates to effective communication is simply that the written or spoken information to the patient must be as clear and understandable to people with disabilities as it is for people who do not have disabilities. Physicians and healthcare providers must make reasonable accommodations in order to provide what's called auxiliary aids and services to patients. And this is to be provided at no additional cost to the patient. This is a requirement of compliance and to be in compliance with the ADA. Auxiliary aids and services are fully dependent on the type of disability that the patient presents with. Typically, these things can be discussed before a patient makes an appointment or as part of the initial intake. Auxiliary aids and services is dependent on the type of disability. So for example, patients with visual impairments, they may require and need qualified readers, braille, print, audio recording, other type of printed information, or even computer screen reading programs that now can be accessible. In patients who have hearing impairments, the office may be required to provide a qualified sign language interpreter, a qualified note taker, real-time captioning, or detailed written material above and beyond the typical written material. Patients with speech disabilities may need to have qualified speech-to-speech translator, taking more time to communicate with those types of patients, communication boards or services that are now available. Aids and services that are available to patients have changed vastly over the last 20 years of my work in this area. Currently, the technology that is available and evolving can make effective communication with hearing or visually impaired patients much easier and much more cost effective. There are a wide variety of technologies available, even on electronic charting through open and closed captioning or video phones, and interpreters sometimes available within a matter of minutes. The other important area to consider is communication with patients over the phone. There is a relay system that has been in place for many years, free service, that is available in a communication intermediary for patients with hearing and speech disabilities. These are considered very important for purposes of communicating lab results, follow-up visits, test results, and typical information that is communicated to patients over the phone. The question often comes up as to whether using family members as interpreters is appropriate. Using family members is frequently not sufficient under the ADA and frankly may violate physician-patient confidentiality. For example, think of a situation with a psychiatrist treating a patient who may be hearing impaired. They may be seeking to talk with the psychiatrist about family members who may be utilized in the interpreting process. There may be concerns about keeping clinical issues and prior diagnosis confidential from family members. So all of these issues should be closely examined when considering having family members as interpreters. In the past, malpractice lawsuits have been considered and brought even when the physicians or other healthcare facilities have provided the appropriate care. That is simply because there was a lack of communication with the patient in understanding of the treatment provided or offered, and a lack of consent for failing to communicate, in particular about ongoing treatment plans. There are patients whose treatment, for example, for cancer may be evolving over the matter of weeks or months, and the offices need to ensure that there is ongoing effective communication with patients. The same is true with understanding the side effects from long-term medication use or changes with medications, as well as progression of chronic symptoms. All of that requires ongoing effective communication with disabled patients, and not just one time of effective communication, perhaps at the time of the initial visit. Failing to effectively communicate with patients does in fact fall under the guidelines of the ADA as inadequate communication that would be different from a non-disabled patient could violate the ADA for healthcare offices. It is important that if there is any issue in terms of compliance, that physicians or healthcare offices do in fact consult with counsel. Physicians and healthcare offices may want to consult with business managers or accountants to determine if there's a legal way in their medical practice to absorb the cost of auxiliary equipment and services, in particular some of the new technology that is available to patients, in order to ensure that there is compliance with the ADA and, most importantly, effective communication with all patients covered. Switching gears now to another area that comes up quite often in the area of the ADA, service animals. And service animals has certainly dominated a lot of public communications and news stories in the last number of years. I've handled service animal issues and civil rights filings of discrimination as it related to service animals for the last 20 years as well. And in the first several years of that practice, it was always quite confusing to the offices and frankly to all involved as to whether an animal was in fact a service animal and what in fact was the definition of a service animal. Thankfully, there's been some definition of this as of late. In Arizona, the service animal description has now been defined in compliance with the ADA. And a service animal is a dog trained to perform disability-related tasks or work for the benefit of a person with a disability. Service animals are now routinely utilized for individuals to manage their medications, provide calm for psychiatric patients or patients with post-traumatic stress disorder, service animals to put the handler on alert of an impending seizure, and any kind of allergy alert as well. So basically performing remarkable tasks by service animals for patients who have disability. The important issue for medical offices dealing with a service animal presentation to the office is that the ADA and the companion Arizona law indicate that limited questioning of the service animal and the handler is allowed by law. The medical office may not ask questions about the individual in terms of their actual disability. They may not demand to see certification, identification, or other proof that the animal is in fact a service animal. The service animal need not wear one of those service animal vests that people are familiar with seeing for many years, typically in the setting of a visually impaired patient. But the office can ask if in fact the service animal performs tasks for the patient and what tasks the service animal performs for that patient. That is the limited area of questioning that can be made of the patient. Service animals, however, should not be confused with comfort animals and certainly not pets. Under the ADA, service animals are recognized as being protected, but comfort animals are not. The office may maintain a no pets policy as long as it is not used to exclude service animals. So typically one will see a sticker on the door of the healthcare provider's office that says service animals welcome. It can even say no pets allowed as long as service animals are noted to be welcome to the office. Further, under the ADA and Arizona law, a service animal, even if a service animal, can be excluded from a public accommodation if certain issues are raised. If the animal, even if a service animal, poses a direct threat to the health and safety of anyone in the office, if the animal is not housebroken, if the animal is out of control, poses an undue burden on the establishment, or fundamentally alters the nature of the office, then there is a legitimate reason for exclusion. I was recently asked to discuss and evaluate a complaint in which a service animal was denied access to a procedure room in which a handler was undergoing urodynamic studies. So the issue of hygiene, given the type of studying that was done, was appropriately allowed as a reason for excluding the service animal under those circumstances. The facility was not fined and the investigation was dismissed because that was a legitimate reason for denying access to the service animal. Typically, when there is a complaint of a violation of the ADA, be it for interpreting services or service animal, as we've discussed today, the allegations or complaints are issued by the Attorney General's office. The patient has 180 days to report the denial of services to the Arizona Attorney General's office or the U.S. Attorney General's office. The AG is compelled to investigate any claim that is made and open an investigation. Therefore, if you receive a letter of an investigation, do not believe that you've automatically been fined or will be found to be guilty in that setting, but the Attorney General must investigate any claim, no matter how illegitimate it might seem in the written complaint form. The AG then provides the office the opportunity to respond to the investigation and complaint, to provide any documentation, and to make available for interview any staff. The physician's office should prepare that response in a timely manner. If they feel it is appropriate, they should contact their insurance company to find out if they can be represented by an attorney in the preparation of the response. But again, be timely and thorough and responsive. Typically, the Civil Rights Division of the AG's office, either U.S. or Attorneys General in Arizona, they have a very long list of cases. The Civil Rights Division may have you prepare your response in a very prompt manner, but don't be surprised if it takes over a year for there to be any findings or conclusions, even a dismissal. Typically, that is the longest part of the investigation. The Civil Rights Divisions from the Attorney General's office will contact the office once there is a response with inquiries about whether there should be any further investigation, interviews, or any conclusions reached by the Civil Rights Division. Typically, those involve, if there is any kind of penalty, a revision of policy, a small fine, or even something as simple as putting a sticker on the window of the office that says service animals are welcome. It is very unusual for there to be anything more extreme on the part of the Attorney General's office, and typically that can be managed with procedures and policies that are redefined to make sure that the office is in compliance with the ADA and that all staff is trained in compliance with the ADA. It is also helpful at times, even without having a complaint filed by any kind of attorney general, that a medical office think about their policies and procedures and perhaps even have a designated administrative person to address when situations arise. For example, it is often helpful that if someone presents to the office with a service animal, that there is somebody, either in administration or office manager, who can come out to the receptionist area and greet the patient and make sure that the situation is handled appropriately. All of this is in an effort to make sure that any issues can be stemmed at the outset. Typically, it is known that patients file malpractice cases or complaints with the Attorney General's office if their initial interaction with the office is inappropriate, or if they just simply feel as though their needs or questions are not being appropriately assessed. So, in conclusion, the ADA and the Arizonans with Disabilities Act does in fact protect and provide for a number of services to be allowed to patients, but also to allow the office to understand their rights, and in particular, if there's any kind of situation that impacts the office's ability to conduct medical care and treatment, or impacts significantly other patients in the office, that there are reasons and exclusions allowed by law. And thank you. If there are any questions now, I'm happy to address any specific situations or questions.
Okay, thanks, Chrissy. That was excellent. We've had a couple of questions come in. I'll just run through the first one. One of my patients is deaf. Can I use one of their family members to use sign language? They seem to understand what I'm saying to the patient.
That is always a question, because not only does the patient typically come in with a family member, but the physician assumes that this is someone who has accompanied them. They're obviously aware of any healthcare issues, so it seems as though that would be a natural solution to the situation. Again, I talked about early in the discussion that there are times when that can actually lead to sensitive information being exposed or described with the individual, for example, in the psychiatry situation. But again, the most important question is just how complex is the information that is being communicated? Because often, if it is complex, it is most beneficial to the provider and to the patient that that be done through an interpreter, and making sure that the interpreter, for example, if it is American Sign Language interpreter, if that is what the patient understands and their language of fluency, then that is the type of interpretation that should be provided. Because you can imagine that if the information is complex for the patient, it's probably complex for the patient's family member. So in general, I would caution having a family member provide interpreting services unless it is very basic information that is being communicated, or very routine doctor's visits, for example, maybe an annual appointment and a stable patient. But most importantly, I would be certain that the patient is understanding and comfortable with the interpreting services if it is to be done by a family member, and that everybody involved understands the limitations of that.
Okay, thank you. And another question. I don't believe a patient has a disability, but they want me to complete a form stating that they have one. How can I be certain that they have a registered disability?
That question routinely comes up for physicians who are asked to fill out some sort of Social Security disability or other disability form for patients. I do not believe that there is any requirement or any ability to search by a physician as to whether a patient has a confirmed disability. But the most important thing to remember is that you are under no obligation to fill out a disability form for a patient if you feel that you do not have sufficient information to make that judgment. Typically, those forms have a requirement that the healthcare provider that fills it out has personal knowledge or information supporting the either finding of disability or the disability that is being alleged by the patient. So I would be very open with the patient and indicate that you just simply do not have enough information to fill out the form if you've got any question about the patient truly having a disability, and recommend that the patient seek that to be filled out by perhaps another provider. Again, there is no obligation that the patient demand that the physician fill out a disability form. This does not violate the ADA simply because the physician does not have enough information to support what the patient wants to do. So I would definitely inquire further, but not feel obligated that those disability forms need to be verified by someone who doesn't have sufficient information.